Welcome everyone to this meeting of the Safer Healthcare and Biosafety Network. My name is Paul Grime, I'm chair of the network. So very welcome everyone. The list of participants should be visible to you, and there are a number of apologies which will be listed in the minutes when they're circulated. The minutes of the last meeting that we had on the 17th of March this year have already been circulated. Does anybody have any comments or amendments from those minutes? No?
Nope.
Okay. In that case, we'll get straight on with our first item on the agenda. We have several presentations this morning, so we'll try and keep quite tightly to time. But we're very pleased to welcome David Osborn this morning on the Covid Airborne Transmission Alliance and the UK Covid-19 public inquiry. David is an occupational health and safety practitioner, formerly head of safety, security and emergency planning in Wessex Water. He's a consultee member of HSE's COSH Essentials Working Group and assists in preparation of direct advice sheets relating to various industry sectors. So he joins us this morning to talk about the COVID Airborne Transmission Alliance, in which he assists the executive team with health and safety advice and assistance. So David, over to you.
Okay, thank you very much. Just to check, are you seeing me and hearing me okay, Paul?
Yep.
Okay,
Yeah.
We'll carry on then. Well, good morning, everybody. Thank you very much for giving me this opportunity to explain who and what CATA is and outline our involvement at the public inquiry. Just for information, I've actually joined SHBN. I'm very interested in what you do, so I look forward to meeting you at future meetings, hopefully, unless you've had enough of me at the end of this one. We'll see. Okay, so just to get started, the aims and objectives of CATA. Now, I'm not going to read this lot out. I'll ask Ian to include these in the minutes, but suffice it to say, it's all about helping the public inquiry team. Learning lessons is the order of the day. We need to analyse what went on over the last 3 years, learn the lessons, and be better prepared for another pandemic, or indeed a resurgence of this one, God forbid. Yeah, that's the objective. So CATA, how did we evolve? Where do we come from? Now we have to really turn our minds back, I'm afraid, to those difficult days of January 2020. This new virus had been identified, very close relative of the first SARS. We knew this very well. Was a respiratory disease transmissible in the airborne route through aerosols and droplets. And indeed, that was accepted by, I think, our scientists. The IPC guidance reflected this, and it also confirmed that the precautionary principle would apply. So the NHS then geared itself up. Precautionary principle is what the name on the tin. If you're not 100% certain of something, you err on the side of caution. That's my paraphrase of that. So the NHS geared itself up for the use of FFP3s, started the programme of fit testing and training and such like. And then we skip forward to March 2020, and there was a rapid U-turn, which I think caught a lot of people in the medical profession by surprise. And all of a sudden, it wasn't going to be RP, respiratory protective equipment, any longer, FFP3s and such like. It was going to be fluid-resistant surgical masks, type 2R masks, except for the certain procedures, AGPs, some generated procedures, and certain locations which were perceived to be of particularly high risk. In that same guidance, when it was produced, interestingly, the term precautionary principle was dropped. A number of commentators would say that that was throwing caution to the winds. Some people hold that view to this day. And at the same time as well, the disease, which had been provisionally declared as a disease of high consequence, that classification was dropped. Now, by that time, we had thousands of deaths across the world, and it was known to be spreading fast, particularly bad in Italy, of course, as you'll recall. In Italy, by mid-April, they'd had 200 healthcare workers die of COVID through their work. I think it was 1,700 so infected, COVID positive. And the impact on our healthcare community was quite foreseeable, sadly. These organisations got together, a large number of them concerned. These were colleges, royal colleges, professional institutions, were concerned at the list of AGPs that the respiratory protection was restricted to was not adequate. It was not complete. So you'll see that the procedures on the screen there. Let's go NGT tube insertion, dysphagia, which is swallowing assessments, chest physiotherapy, and CPR. Now, interestingly, a few years earlier, CPR was an AGP, and now it wasn't an AGP anymore, which I find strange. Okay, so this alliance formed. This was a unique event in the NHS history. Nothing like this had happened before. All these organisations coming together. I'll put them on the screen with a single aim of campaigning to get better protection for their members, healthcare workers in the front line, to prevent disease and death, which we could see happening in Italy, and we didn't want it to happen here. We had an MP reporting the words of a doctor in a select committee late March, saying it's absolute carnage in NHS, in A&E, utter chaos. We don't have any proper PPE, not the FFP3 masks we need. I feel like we're being thrown to the wolves here. Some of us are going to die. And indeed, those were prophetic words. And the response to that from a senior director in NHS England was perhaps some education is needed. So, as well, of course, as those organisations, they're very close liaison with the Royal College of Nursing and the British Medical Association, all of whom had the same concerns as we did. We campaigned, there were press releases, there were letters to just about everybody we could think of that had any influence in the matter, any clout. On the whole, the responses were either nil, we got no reply whatsoever, or those replies on the whole were just trite platitudes. The safety of our healthcare workers is of prime importance. You know, we're working tirelessly to provide the right PPE, etc., but no response at all to the substance of our letters, the technical points, the concerns being raised. Are you all hearing me okay still?
Yep.
Yes. Yes.
Good, thank you. Just checking. Okay, and most importantly, there was no change from the droplet-based policy. Still considered not to be airborne. An exception to this, to be fair, HSC, we did, whenever we went to the HSC, we got a considered response. Didn't always agree with it, but we got the courtesy of a detailed response, and sometimes from PHE as well. Okay, next year, more organisations joined us. Early 2021 landmark research called the Aerator study showed that actually coughing, breathing, talking generated as much airborne aerosol as some of the defined AGPs in the official list. And so we then considered that the official AGP list had no relevance and that proper respiratory protection should be provided for all close quarter care infectious patients, not just the AGPs and those particular locations. The name AGP Alliance therefore was no longer relevant, so we changed our name for the first time, it wasn't to be the last time, to Covid Airborne Protection Alliance, CATA. Then along comes the public inquiry, and some of our members chose to take a different route to the inquiry. Some of the trade unions went a different way, some of the doctors' associations went a different way, but we were joined by others. Patient Safety Learning, we were pleased to welcome on board, and we included some individual people who had specific knowledge and were able to make a very, very valuable contribution to our work and our research. Okay, so we had to have another name, so our second and final name became the Covid Airborne Transmission Alliance, as we are now. Now we're core participants of Module 3, Impact on Healthcare and NHS. We have provided evidence to Module 1, and we may, and I'm very willing to provide evidence to Module 2 if requested to do so by the inquiry. We appointed a very well thought of, reputable law firm, Saunders Law, very experienced in public inquiries, Kent Blood, Grenfell, etc. And they are legal representatives at the inquiry, and we're doing a grand job for us. So let's our key points. What are our main submissions to the inquiry? I'll just put the headlines up, and then we'll talk through some of them in a little bit more detail. Poor planning and preparation. You'll have heard, some of you will have heard a lot about that at the oral sessions over the last few weeks at the inquiry as module 1 gets underway. Crucially, the airborne route, very important. Lack of respiratory protection for our healthcare workers, also crucial. There, as I understand it, many viral infections that cause sequelae beyond the infection itself. And we don't believe that that was adequately considered, particularly the impact on the healthcare workforce. And then finally, the recognition or not recognition of occupational exposure by NHS trusts and NHS boards and the middle regulations, which if you know that acronym, we'll come back to that. So taking those in turn, poor planning and preparation, we believe that the stockpile, this massive stockpile that was created around about 2009 following swine flu, was not properly managed. When you have a stockpile of equipment, you should rotate it, you should take equipment out for use in operations and replace it with new, so that you don't end up with lots of equipment past expiry dates. And these materials do deteriorate with time, fabric and materials. The NHS is such a diverse workforce. There's no evidence that we can find that these factors were considered. Racial and religious. Racial, the reason being that different races, different ethnic groups have different facial features, sizes. Ladies, small Asian women, for example, very difficult to get tight-fitting face mask respirators to give a good seal. And also there are some faiths where the men are required to wear beards. Now, if you've got any facial hair, even if it's just stubble, tight-fitting masks do not work. And so we believe that there was insufficient consideration of the Equality Act 2010. And then I refer to a crucial meeting that happened in 2016, subcommittee of NERVTAG, and this crucial decision was made, which we believe was going to have massive consequences 4 years later. All general ward, community, ambulance, social care staff will wear fluid-resistant surgical masks for close patient contact in a pandemic. I don't think I need to say any more. Okay, the transmission route. We maintain COVID is transmitted by the airborne route, always has been and always will be. As people cough, sneeze, I think I've covered this enough. I'll just move on from that. Its normal functions produce aerosols in the air, which people nearby, including healthcare workers tending to them, will inhale. There are other routes of transmission as well, of course. There are ballistic droplets, which emanate from a person's mouth or nose, which impact directly on the mucosa of another person and directly transfer the disease. And honestly, how often does that happen in reality when people are wearing masks as well? So I don't believe that is the main cause of transmission of the disease, and I think my colleagues in CATA think the same. Fomites, where these droplets have fallen onto a surface and they're picked up by the hands and transferred to the eyes, nose, and mouth, or indeed food someone's eating and getting to the body that way. It was well known before the pandemic struck. As I say, it was accepted initially by the scientists, and we don't believe that further research was needed. It's airborne, get on with it, provide airborne precautions, proper respiratory protection. SARS-1 was airborne, MERS was airborne, and viruses, they evolve, but they don't evolve for the worse. They don't go from a successful route of transmission to one that was less successful. As far as we know, it has never happened. They go the other way. Now, during the pandemic, a lot has been talked about misinformation, whether it's to do with vaccines, whether it's to do with COVID being airborne, etc. And we believe there are two main sources of misinformation about this. Probably the biggest ever in the world misinformation came from the World Health Organization itself. All of this was published at the time, refuting any suggestion by renowned experts in aerosol science that COVID was airborne. Dogmatically, it was not airborne, they said. Closer to home in the UK, the Department of Health, Public Health England, etc., the IPC cell that generated the guidance that had to be followed in hospitals and everywhere else, all claiming that it was not airborne, it was only these droplets impinging on other mucosa that were responsible. Why is that important? Because if you declare a disease to be airborne, then it's beholden on you to provide proper respiratory protection for the people at the front line. Another disease, TB. I think everybody acknowledges that this is an airborne disease. Let's have a look at it. There's the bacillus, there's the size of it. It's recognised that will easily become entrained in an aerosol droplet and be transmitted. There's our familiar SARS-CoV-2, tiny. And in proportion, that's what it looks like. Now, if these great big lumbering great bacilli can entrain themselves in an aerosol, then so can something little, tiny little thing like that. And of course, there's evidence that in aerosols, when you analyse them, you find the RNA of the virus in them. At least there was an apology. The World Health Organization chief scientist publicly expressed regret. They got it wrong. They should have recognised it was airborne much earlier. We haven't had any such apology from any of the UK health authorities, but we did have a useful comment from the chief medical advisor of UK Health Security Agency, saying we no longer believe that the strict dichotomy between aerosol and droplet transmission has relevance, or words to that effect, an encouragement sign of the way things should go. However, that hasn't filtered through in the past 9 months since the statement was made to the IPC guidance. Sadly. Failure to provide respiratory protective equipment. Okay, let's be clear. Surgical masks are not, never have been PPE as defined in UK law. Okay, if we finish this meeting, go and look on the HSE website and you will see under their pandemic page, they do not provide full respiratory protection against smaller suspended droplets in aerosols. They are not PPE, full stop. Now, one of the things we health and safety people always advise duty holders to do is listen to your suppliers. They are more competent, they know more about their product than we do. We should always take account of their observations. If we look at the NHS's own supply chain, is the advice that was given: surgical masks are not effective at protecting the wearer from airborne diseases such as coronavirus. It couldn't be plainer than that. And that guidance was online from May 2020 right through till 2022. Whilst at the same time IPC guidance was being published saying effectively the opposite. And note, the testing of medical masks is in an outbound direction, not inbound. That's what they're designed to do, is protect other people from the wearer. And the filtration is suitable for bacteria. Well, you've just seen a comparison of the size of a bacterium and the size of a virus. I think that speaks for itself. Okay, then we had this. I'm not going to dwell on it too much, but we had healthcare workers peeling off labels that have been stuck on, extending the shelf life. So this particular batch, by the time it came to be used, was 9 or 10 years old, and the materials do degrade. They were assured stringent tests had been performed and a new shelf life was appropriate. CATA begs to disagree, and we will suggest pass information to the inquiry that those tests were not stringent and that course of action was not appropriate. And the IPC guidance itself was prescriptive. FRSMs must be worn when delivering that close quarter care. And yet, if you look at the regulations of COSH, require RPE with a protection factor of 20, that is FFP3 level equipment. When you've got microbiological hazards that are airborne, that's what's required. And there was they were different, and in our opinion, the COSH regulations took a bit of a back seat during that stage of the pandemic. Okay, finally, in for time, not too bad. So I'll have to speed through this because I do want to keep to the time scale. We submit to the inquiry that they need to investigate the HSC's enforcement or otherwise of the reporting under MIDL. We believe there was massive underreporting. NHS employers had some contribution towards that by issuing flawed guidance, and it prevented the powers that be, and indeed the workers themselves, from having an overview of what the disease it was having in the way of impact on them. And it may have impaired healthcare workers' ability to get compensation, payouts for insurance and state benefits, either immediately or in the fullness of time. May 2020, the MPs wanted to know, what is this pandemic doing to our healthcare workers? They needed to know. The HSC chief executive went in front of the select committee and couldn't tell them because it was recognised that MIDL was being underreported. The MPs were not happy with that, and they requested that the HSC was more proactive in their insistence that cases of disease and death were properly recorded. We don't believe that happened. If anything, the level of reporting went down. Okay, we'll have to speed it through, I'm afraid. To give you an idea, a survey carried out by a colleague in CATA, over half the NHS trusts in England seem to have not had one single healthcare worker infected with the disease through their work, which is unbelievable. Similarly, over 3/4 did not have one healthcare worker die of the disease through their work. When in hospitals, at least 14,000 patients died of hospital-acquired COVID in England and Wales. So how come healthcare workers are so strangely immune? Okay, let's just to wrap up. What does MIDL require? Reasonable evidence someone contracted the disease through their work. An example was given of healthcare treating patients who'd had COVID-19. Some of the excuses, if I can call them that, for not reporting that were given by the trust that we've come across. The worker didn't have a COVID test result, positive test. That's not necessary. The law doesn't require that, just simply a diagnosis, which can be on symptoms alone. Testing was not always available, etc., etc. We won't report because we were providing PPE in line with national guidance. Wrong. No legal basis in MIDL whatsoever. There is no reference to whether PPE was being worn or any other control measure being applied. If a person got a disease or had an accident or died through their work, it's reportable, full stop. Okay, and finally, the last excuse we came across was we can't prove you got the, we can't prove that you caught the disease through your work. Again, wrong. There's no foundation. There's no requirement for absolute proof, and indeed, it's absolutely unreasonable to expect it. The test is the balance of probabilities. Is it more likely than not, on a 50-50 basis, that the person acquired their disease through their work? And people are working every hour that God sends with highly infectious patients. They go out into a lockdown community. Is it likely they've got their disease in the community? I should say not. I think I better stop there. I'll hand back now, if I may, to Paul.